The aims of this particular talk is to discuss the structural conditions which cause true incontinence and just reinforcing that these are quite rare. But I'll also briefly touch upon non structural conditions which cause intermittent incontinence but have a small structural component. One way to look at this is there's a hardware problem and a software problem. What Sukanya was talking about was the software problem. What I will talk about is the hardware problem. Or another way of looking at it is that you have to decide when to call in the plumber so he can fix the plumbing. The two talks that I'm doing are somewhat interrelated, and that's why I'm covering some basic principles about bladder function in the first talk so that the second talk makes some sense. Bladder has two important functions, storage and emptying. Again, one way to look at the bladder is a univentricular heart that beats about 6 to 8 times a day. That's one way to look at it. It stores and then empties. The storage function requires a competent sphincter to prevent leakage and a compliant bladder which can stretch without elevating the pressures too much. And the emptying function requires the same sphincter which was closed all this time to open and a bladder to contract. The mechanisms behind incontinence can be summarized into three overlapping groups: failure of storage, failure of emptying, and true structural cause that bypasses normal continence mechanisms. Mind you, even some of these true structural causes have elements of the other two groups. Hence, you have to think about every patient as, individually without excluding any of these subgroups. Looking at the failure of storage, weak sphincter or poor outlet resistance is known to happen in children who are born without a properly anatomically constructed sphincter, commonly seen in extrophy, which is rare, but that's the commonest place where the sphincter is not anatomically constructed. But also in conditions such as ectopic ureta or ureterocele, where the bladder neck is affected. Cloacal malformations are a type of anorectal malformations which have poorly formed bladder neck. And spina bifida, one would think that when your spinal cord is abnormally formed, that the outlet resistance will be very bad. But I'm sure Antoinette will talk about this. But it is incredibly uncommon to have poor outlet resistance in spina bifidas, and majority of them actually have a very strong outlet resistance. The other group is where the storage is compromised is one with poorly compliant bladders, and the commonest one is posterior urethral valves. We'll come to that in a minute. Talking about failure to empty, this is where this can happen when either the muscle doesn't contract or the sphincter doesn't relax. The sphincter not relaxing seems to be far more common, and it's a software problem, something that Sukanya was indirectly alluding to. We call it sphincter active voiding, where the sphincter is contracting concurrently with the detrusor, which is contracting, and there's a complete discoordination of voiding. It can happen in neurologically normal or abnormal children. The other one is less common. It's a myogenic failure, where the detrusor just doesn't have inherent adequate ability to contract and expel the urine. One of the subgroups that we need to be aware of for this particular one, not technically a myogenic failure, but just a myogenic inadequacy, is the trisomy 21s. Now the true plumbing causes, the urological causes where the mechanisms are anatomically wrong. The one that I would like you to remember is the ectopic ureta, because although rare, this needs to be excluded in majority of the children with daytime wetting, and it is incredibly difficult to pinpoint the ones. It's like looking for a very rare species of a plant in the Blue Mountains. So unless we all know that we're looking for it, we will not look for it. Second are the rare causes, extrophy. Posterior urethral valves are common, but the diagnosis is usually obvious at birth. Rarely they present beyond infancy. Neurogenic bladder, I'll leave it to Antoinette to talk about that. Ectopic ureterocele and cloaca are rare. So this is probably the most important slide of this talk, is when do we all in the community or in whatever practice setups we are in, when is it that we should suspect that a child actually has a plumbing problem? As we said, as Patrina showed the wonderful diagram of how you classify incontinence, continuous wetting, I must add, has two causes. One is neurogenic, but the other one is a true plumbing problem, where a child can wee, but is also wet between wees. You will never have a dry nappy or a dry pull-up or a dry jockey, and that is where you should start thinking whether there is continuous dribbling because of an ectopic ureter. For some reason, urinary tract infections, especially the febrile ones, are incredibly uncommon with software problems. They seem to be far more common in the hardware problems, in the true urological problems. So if a child gets a febrile urinary tract infections, the red flags must go up. Is there an underlying urological problem? And the last two are very obvious. If a child has antenatally diagnosed hydronephrosis, then the wetting is probably related to that. Or if he's had surgery, especially badly done, then it's probably a cause or effect of the surgery. As I said, one of the important conditions, probably the only important condition that I want you to remember, is an ectopic ureter in a child with daytime incontinence. This is a condition where the ureter misses the bladder continence mechanism and inserts distal to the sphincter, thus resulting in continuous dribbling. It can happen in a condition with a duplex kidney, where only a part of the kidney bypasses the bladder. And in this situation, the upper pole of the kidney usually is the culprit. And as you can see, the ureter can inserts distally. It could insert either in the vagina or in the urethra, or you could even see the opening in the introitus. The same thing could happen with a single kidney, not a duplex kidney, and the ureter would insert itself distal to the bladder. The message is keep looking. If a child is continuously wet, keep looking for this. Sometimes it's obvious, such as that unexplained opening in the introitus, which is, of course, an ureter coming from the right kidney. But as I mentioned before, it could insert anywhere along the urethra or on the anterior wall of the vagina. And not all these openings are easily seen. So suspecting and investigating remains the key. I will come to the investigations in a minute. Again, just reinforcing that constantly wet child is a good reason to suspect this. Small damp patch on underclothes between normal voids, urinary tract infections, and antenatal ultrasounds with abnormal kidneys are all common presentations of this condition. There's a lot of investigations we could do. In the olden days, we used to do IVPs. Now CT, MRI, and PET scans are really helpful. They all have their problems. CT scan has radiations, and MRI scan needs an anesthetic, especially in the toddler age group. And then there is the laparoscopy, which can also pinpoint this diagnosis. It is difficult to decide how much you should investigate in which child, and often it's a clinical judgment issue. I'll discuss this with an example. So this girl was 9 years old and always wet, and an intravenous pyelogram was done. Majority of you would think this is a reasonably normal intravenous pyelogram, shows two normal kidneys, they're not dilated, ureters seem to be coming off it, going into the bladder, and the bladder looks reasonably normal. This child's continuously wet. So when a CT scan is done, as you can see, the two normal kidneys are confirmed. But if you look closely at the top of the left kidney, there is a small portion that looks not right. And in the axial sections, you can see a dilated ureter just behind the bladder. So in fact, this particular upper pole is not having a lot of function, but just enough to produce urine to keep the child wet, which is exiting itself into the introitus through a dilated ureter, causing infections and wetting. This is the situation where we have to deal with this. And because there is no function in this upper pole, as seen on the CT scan, our choice would be to take it out. There are other situations where there would be enough function in this upper pole, and we would join the ureter, join the two ureters together and make sure that the upper pole drains into the normal ureter, into the bladder, thus making the upper pole continent. And the incision looks somewhat like that. So there are a number of options, but again, the key is to actually suspect and diagnose. As I said before, exstrophy and epispadias are obviously situations where the sphincters are not formed, but they're thankfully very, very rare. Now, Extrophy is where the bladder plate's exposed, and these are the two ureteric orifices which are intubated. And this is epispadias, where the skin has covered over, but as you can see, the bladder neck's open. So there is no hope for these children to be continent without surgery. Even with surgery, the continence is not great because you're trying to reconstruct a sphincter that has never been constructed. And the bladder plate, as you know, is exposed and fairly damaged. Following the primary reconstruction of extrophy, the child can often have continence issues and often needs revision surgeries, which could be to enlarge the bladder or to tighten the sphincter. In either case, they need additional supporting mechanisms, and these are often very complex issues for the urologist to deal with. More common and probably less complex is the condition called posterior urethral valves, which I mentioned to you before. There's two ways posterior urethral valves can present as incontinence. One is a misdiagnosis where the children get to school age without having been diagnosed, and they're voiding against an obstruction, which these are valves in the urethra which are obstructing. And because they're voiding against obstruction, the bladder becomes hypertonic, high pressured, and you get incontinence. The other way you could have incontinence in posterior urethral valves, despite an early diagnosis and a fix, is because of the underlying bladder dysfunction. We call it the valve bladder. This tends to get better with age. So if you plot the continence rates of posterior urethral valves with age, as you can see, majority of the children have continence issues till they get to puberty, and then they seem to resolve. So you will all probably see one of these kids in your practice at some stage. And just be mindful that the bladder dysfunction could be playing a big role in the incontinence, in addition to possible polyuria because of poor kidney concentrating ability. I'll just illustrate this with an example of an 11-year-old boy who was not diagnosed and was wet day and night, had UTIs, and the ultrasound suggested a neurogenic bladder. His creatinine was on the higher side. But when a cystourethrogram was done, so that's the bladder. The posterior urethra is much elongated and dilated, and there is an obstruction just at the distal end of the posterior urethra. He's come to the age of 11 without having this diagnosed, so he's clearly voiding against a fixed obstruction, damaging the bladder, the kidneys, and affecting his continence. The last condition that I want to talk to you about, which can cause dribbling, not so much daytime wetting, more post-void dribbling, is a diverticulum of the urethra, typically in patients who have had hypospadias repair, especially if the hypospadias was very severe. It will be evident because the child the history will be that the dribbling has become worse after surgery. And if you examine the child, you should be able to see a bogginess on the ventral surface of the penis. These are easy to fix. Finishing off with the very uncommon causes for which I have no gory pictures to show you is the cloaca. I mentioned to you it's a rare kind of an anorectal anomaly, an ectopic uretrocele which damages the bladder neck, and the very uncommon bladder neck weakness in spina bifida. Once again saying that is far less common than true neurogenic detrusor overactivity. Now, I mentioned at the start that one of the aims of this talk was to discuss partly structural and partly software problem which can cause urinary incontinence and is labeled as a urological problem. It's called a neurogenic, non-neurogenic bladder. It was described by Hinman and Allen, and it's also called the Hinman-Allen syndrome. It's quite a dangerous condition, but again, fortunately, it's a bit rare. There are some syndromes associated with it. These bladders behave like neurogenic bladders, but despite every possible test, we are not able to display any abnormalities in the central nervous system. They damage the kidneys, and the treatment is along the lines of a neurogenic bladder, which I'll leave to the other speaker to elaborate. So in summary, true plumbing structural causes of wetting are quite rare, but because they are rare, they're difficult to diagnose. They are amenable to corrective surgery, and majority of the children can be completely dry if they're diagnosed on time and treated appropriately. Surgery also has a role in some failed medical management in cases where there's an overlap between structural and non-structural causes, and we'll discuss a little bit of this in the other talk. Thank you.
Okay, time for one question. Any questions? Yes, Nigel.
Ani, you mentioned antenatal hydronephrosis as a red flag. That's pretty common. Can you be more specific than that?
I'm thinking, Nigel. No, I can't. You're absolutely right. It's more common than hernias and hydrocele, to be honest, antenatal hydronephrosis. No, what I would say to you is that if there is a child with incontinence, I would always ask for antenatal history. And if they say that there was an antenatally detected hydronephrosis, then I would perhaps be more skeptical about looking for a urological cause. But there are no pathognomonic features on antenatal ultrasound which can correlate directly to incontinence.
Except
postnatally.
bilateral. If you have bilateral hydronephrosis in a boy, you might want to think about posterior.
Again, that's fairly common, and not all of them have a cause related to incontinence. So.
Probably the other comment I have too is with posterior urethral valve. Annie and I have done some work on these. A lot of these children get polyuric, and in terms of if they're incontinent and they have posterior urethral valve, there's an increased risk if you do alarm training and they're polyuric that you increase the pressure to their kidneys. So I tend not to do alarm training if they're polyuric. That's just what I do. Do you want to comment at all?
The ectopic ureters. You mentioned that sometimes that can be not related to a duplex kidney. Is that like common or
No,
really uncommon situation?
Uncommon. Duplex kidneys with ectopic ureters are far more common. And the other thing I did not mention, not to make it too complicated, is that they're typically associated with incontinence only in girls. So boys are lucky.